Good morning, viewers, and welcome to another episode of Monitor Your Health. My name remains Dr. Femi Ogunremi. On this program, we aim to educate the public on contemporary medical issues. And today, we're choosing another interesting topic, and that is breast cancer. We're looking at breast cancer from another dimension today. We previously discussed breast cancer as to what we do if we see symptoms in the past. We also discussed a little bit around screening, but today we want to take it a little bit further. I have with me Dr. Georgette Oni, who is an oncoplastic surgeon from Nottingham Breast Institute. Today, she will be telling us what are the roles of an oncoplastic surgery in the management of breast cancer. You're welcome, Dr. Oni. Miss, because I know it's different in England now, isn't it?
It is.
For men, but I think Mrs. or Miss.
It is Miss, yeah, Miss.
Miss for ladies, okay. So you're very much welcome to the program today.
Thank you.
Yeah, please, can the audience, can they meet you? Can you introduce yourself?
Of course. So thank you very much for inviting me. I think this is a vitally important topic. Obviously, women making up 1 in 2 of the population, breast cancer, the incidence we now think is greater than 1 in 8. So people are now quoting 1 in 7. So 1 in 7 women are going to develop a breast cancer in their lifetime. So it's a vitally important topic. My personal background, I'm a plastic surgeon. I trained in plastic and reconstructive surgery. And towards the end of my training, I became very interested in breast cancer, mainly because actually quite a few friends and family of friends had developed cancers. And I had already had a big interest in breast reconstruction as a plastic surgeon. So I did a further fellowship, which trained me in all aspects of breast oncology. And now I'm one of a handful actually of plastic surgeons in the country who provide both plastic surgery and breast oncology. So if a woman presents, I see them through from diagnosis, through to management, through to their surgical treatment, and I guide the whole of their treatment. So I'm a plastic surgeon and a breast surgeon all rolled into one. So you get 2 for the price of 1 with me.
That's great, and it's a pleasure to get you on the program today. So we're going to talk about breast cancer. Since we have you with 2 legs, obviously, breast cancer and oncoplastic surgery.
Yes.
Or surgeon. Now, can we touch on breast cancer? How much of these cases, or how often do you see these cases?
So, I mean, it's very common. So like you said, I work in Nottingham, which is a reasonable sized city in the UK. And we probably see the 4th largest number of cancers in the country. So we're seeing between 700 and 800 cancers a year. And obviously it varies in stages, most thankfully in the early stages, but the majority of women are going to come to surgery as part of their treatment pathway. This is one of the largest tumour or cancer groups. So it is vitally important that people are breast aware. They know what's normal, not normal for themselves. They present early when they see symptoms. They get early medical advice, and if necessary, and if it does prove to be a cancer, they get early treatment, because we know that actually now the survival rate from breast cancer is extremely good indeed. However, when you look at it in terms of race, Black women have worse outcomes, currently have worse outcomes than their white counterparts. So I think, so part of my passion actually is trying to educate women, particularly Black women, to really get on board with understanding, firstly, what's normal for them, what to do if they find something abnormal, and to not be scared to kind of engage with the process of treatment, because we know that the outcomes can be very good if they follow a treatment pathway.
Right. Well, during this, your commentary, you talked about Black women being badly, affected, or maybe the outcome is usually worse. Do we have an idea why?
No, so I mean, there's lots of theories. I think there's going to be scientific bits that are yet to be ironed out as to why. We know that we get it younger, we get it in a worse, in a higher stage with with a more advanced presentation. But even if you account for all of that, the long-term outcomes are still worse. So there's going to be a multitude of factors which are contributing to this. But what I always say is there are bits that we can do, and there are bits that the scientists have to do. And so in terms of what we can do, like I say, breast aware, critically important. Getting involved with any kind of research projects or studies that are going, also critically important, because if we are not represented in any research studies, then it's very difficult for them to say, well, why is it that you have a worse outcome than the patient over here has a worse outcome? So really getting engaged with treatment strategies, research strategies, and early sort of intervention awareness.
Right. Thank you so much. So now, oncoplastic surgery. How important is this to the management of breast cancer? If we look at the management of breast cancer.
Well, I think what we need to do is just take a step back, okay, and just start with surgery. Okay, so surgery for the majority of women is going to form part of their treatment pathway. What that surgery is going to depend on a number of things, which will be related to their cancer, size of their cancer, location of their cancer, involvement of lymph nodes, what sorts of treatments they're going to require as a result of the actual, what we call, stage of the cancer. So surgery, broadly speaking, is either what we call a lumpectomy. So you're taking out the cancer with a rim of normal breast tissue around it, but you're trying to preserve an element of the breast as part of that. It's called a lumpectomy, okay? The other way of removing your cancer is to take away all of the breast tissue and your cancer is within it, and that is called a mastectomy, okay? With either one of those two, so either with a lumpectomy or a mastectomy, there can be an element of reconstruction within that, okay? So oncoplastic surgery is basically utilizing plastic surgery type techniques to perform a lumpectomy to try and leave behind an aesthetically, so as near normal a breast as we can. The important thing with oncoplastic surgery, or with lumpectomy in general, is in order to have the same long-term outcomes as if you had a mastectomy, it has to be followed with radiotherapy. And so that is critical. So when I'm counselling patients, I explain to them lumpectomy, radiotherapy can give you the same long-term outcomes as a mastectomy, radiotherapy being the critical bit. Right. And good margins around that cancer. So that's also critical. You've got to get good margins around that cancer.
Wow. Okay. So, and is it every breast cancer cases, all the breast cancer cases that will probably go through this, or how do we select, or how do we know who will be going through this pathway? Or not? Because some people ask questions that, oh, there are medicines they will take, especially when we look at women in our side here, in developing countries. A lot of ladies think we take tablets and they cure. They say that there are herbal, preparations that they can use to actually cure cancer. How do we know who goes in for surgery, who goes in for non-surgical management?
So essentially, you cannot cure cancer unless you have surgery. Okay, so we do have ladies that don't have surgery, but they are on treatment, but we tell them that we cannot cure them, okay, because we are not physically removing any cancer cells from the body. Okay, so I would say that if we're aiming for cure, surgery has to form part of your treatment package. In terms of who gets surgery, the vast majority of ladies will, or the vast majority of patients will. The caveat to that is if you develop what we call metastatic disease. So disease that has stepped outside the breast and the armpit. So if the cancer is going to spread, the first place it normally goes is into the armpit next to the breast that's affected. Okay, if the cancer has spread to other areas of body, so for instance, your liver or your lungs or your bones, that's called metastatic, okay, and we can no longer cure you of that cancer. In some circumstances, we can perform surgery, but for the vast majority of those ladies, they will be on treatment to try and control the cancer, not cure the cancer.
Right. So in England, in the UK, I know that we have even, a robust, I say we have because I do practice in the UK as well. So we do have a robust system whereby you said earlier on that your majority of your, the outcome these days is good, and the patient that you see in England, you're able to actually cure them in a, well, not cure them, to manage them in a way that, at least the outcome is good. And I think this hinges on the fact that you screen well in the UK. You understand? So we have a very, very organized screening process. In developing countries like in Nigeria, we don't have such opportunity. And I know that there's a room for self-examination and things, especially within the community. What do you see? What's the importance of this?
I think screening, so if we look at screening starts at the age of 50. And if we look at specifically Black women, they actually, a lot of them get their cancers younger than that, okay? So you're looking at about 1 in 2 will present what we call symptomatically. So they felt a lump, okay? So screening will not pick up everybody, okay? And screening is only as good as people engaging. So again, if you look at who attends screening, okay, Black women, they tend to attend screening less than their white counterparts. So I think, yes, we've got a screening program, but self-exam is actually quite critical. And presenting early is also quite critical. Why? Because as I have explained, we do present earlier with breast cancer than white counterparts, okay? So, and I think the other element to that is not just picking up the cancer, is what happens next, okay? So yes, we are very structured. We have a treatment pathway. We have times along that pathway. So, within 2 weeks, you're going to get seen. Within 31 days, you're going to have a treatment intervention. By the time we've done 104 days, you should have pretty much wrapped up everything that you need for your cancer treatment. So we are very, very scheduled in the way that cancer treatment is delivered. The other critical thing is we work in a very multidisciplinary team way. Okay, so no patient is managed in isolation. Every single week, I have meetings with oncologists, radiologists, breast care nurses, and the surgeons to plan what that treatment pathway is going to look like for each patient. And whenever I'm sort of sitting and giving the diagnosis to a patient, I explain this to them, that actually your breast cancer care is actually going to be very, very tailored to your cancer. And we're able to do that because we have the infrastructure to provide that.
Wow, that's amazing. I want to touch on this multidisciplinary team later. I want us to really explicitly, discuss it, because it's not something that I see that is robust in Nigeria, for instance, and I want us to touch on it. But before we go into that, the breast cancer pathway, where does, obviously, I think you've explained this, where surgery fits in that pathway, but what pathway are we talking about here?
So once you get your diagnosis, at that point, we then decide what's going to be required to treat the cancer. So broadly speaking, there are 4 types of called treatment. There's surgery, there's radiotherapy, there's chemotherapy, and then there's tablet therapies. Not all patients are going to have all of those modalities, okay? A lot of them, and we've already talked about this, the vast majority are going to have surgery as part of that treatment. Radiotherapy is going to be dependent, not sometimes just on the type of surgery you have. So we've already talked about the fact that if you have a lumpectomy, we would recommend radiotherapy with that. But equally, depending on your tumor size, depending on your cancer size, depending on whether it's in your lymph nodes and lots of other features like your age, we may also recommend radiotherapy anyway in order to reduce your risk of recurrent disease. Chemotherapy, we sometimes give first. And again, it'll be dependent on features of your cancer. So we look at things that the cancer expresses, and we look at the size of the cancer, and we look at whether it's involved with the lymph nodes, and we look at your age, and we make a decision as to whether chemotherapy is going to be the first step in your treatment pathway. Tablet therapy is dependent on whether or not your cancer produces a certain receptor, the estrogen receptor, because the tablet therapy blocks that receptor. So again, this is the benefit of the multidisciplinary team meeting. The pathologist is also there, will go through the features of the biopsy and explain, and therefore tell us, yes, it produces a receptor, yes, it produces, the HER2 protein, for instance, or yes, it's involved lymph nodes. So we can make a decision then on what should be the first step, the second step, et cetera, in that pathway.
Right, brilliant. Now, so the tablets, chemotherapy, and all the like. Then we talk about reconstruction surgery. where does it fit in? How does it come in? When do we talk about reconstruction?
So at the time, so obviously diagnosis is always a very stressful time for women, or for patients, I should say, actually, because we do get male breast cancers. So we tend to go through diagnosis, let that sink in. They spend some time with a breast care nurse, and breast care nurses are actually quite, they're a very, very important part of the team, because especially sort of in my unit, they are basically the contact point for patients. So if they've got any queries, concerns, they go through the breast care nurse. The breast care nurse helps to coordinate what's happening with their treatment plan. So they'll tell them, you need to be here for a scan, or, we're going to sort out an appointment for you to see the oncologist on this day. So they're a sort of, they're a really sort of a good link between the physicians, the doctors, and the patients, just to make sure that all the elements of that journey are moving along in sync as they should be. So we make the diagnosis, we go through that with the patient, we leave them time to sink in. They then come back to what we call our surgical planning clinic. So this is a second visit, and then we go through their surgery. So we talk about the features, we talk about the size, the location, we talk about whether we're going to need to do surgery to the armpit. And then it's at that stage that we make a decision as to whether they're going to need to have or whether we can offer them a lumpectomy or a mastectomy. There's still a patient choice to a certain degree. So if you're a candidate for a lumpectomy, then obviously you can have a mastectomy. If you need a mastectomy, then obviously you can't have a lumpectomy. So it's only in that direction. So patients always get the final sort of say in what they would like in terms of their surgery. Then the next step is about reconstruction. So as I've explained, you can have what I call a partial reconstruction with a lumpectomy, and we talk about the ways in which we can do that. And broadly speaking, with oncoplastic procedures, there are two ways to do this. You can either do what we call volume displacement, which is you take out the cancer and you reshape the breast, and that by and large is using breast reduction techniques from plastic surgery. Or you can do volume replacement, so we're trying to get the breast back to the same volume that it was before we took out the lumpectomy. And that by and large involves using adjacent tissue, so from the side or underneath the breast, to move it into the breast to replace the volume that we've removed. Those techniques are usually done at the same time as lumpectomy. If we move to mastectomy, you can either have what we call a simple mastectomy. That means taking away the nipple, the dark bit of the nipple, and some of the skin, as well as the breast tissue. That leaves you flat on that side with a scar that goes across the chest. So on that side of the chest. That's called a simple mastectomy. There is no reconstruction at that time. If you want a reconstruction after you've had a simple mastectomy, that reconstruction is performed in a delayed fashion. So at some point after you've had that simple mastectomy, you can come back and have a discussion about what your reconstructive options are available to you, If you have a mastectomy, you can have an immediate reconstruction if it's safe to do so. And we found initially in that coronavirus, the COVID outbreak, we were unable to offer immediate reconstructions because it wasn't safe to do so. It meant lengthening the anaesthetic time. And if someone develops a coronavirus infection, we know that you can have worse outcomes after surgery. So during the coronavirus, or the initial phase of coronavirus, we weren't offering reconstruction. So anybody that had a mastectomy was going to go into that delayed pathway. We're back offering reconstructions again, which means that when you have your mastectomy, we can perform a reconstruction at that time, and that's called immediate reconstruction. In some of those cases, we can keep the nipple and the dark bit around the nipple, and in some of those cases, we have to remove it, and a lot of that is dependent on your cancer and where your cancer is in relation to the nipple. So you can either have what we call a nipple-sparing mastectomy or a skin-sparing mastectomy. So we're trying, and the way I explain it to patients, it's a bit like taking the stuffing out of a pillowcase. You're left with the pillowcase and you need to put a stuffing back in, And that stuffing can either be, broadly speaking again, implants or your own tissue. So a lot of the reconstruction that I'm quite passionate about is using your own tissue to do the reconstruction. And invariably that means taking it from other areas of the body. And commonly we use that roll that you have underneath your belly button, the inch that you can pinch below your belly button. We can detach that tissue with its blood supply, bring it up to the chest, do some microsurgery to re-establish the blood supply, and put that stuffing, which is all that fat at the bottom of just underneath your belly button, back into that pillowcase to reconstruct the breast. So that's called free-flap surgery. Implants obviously don't involve taking tissue from anywhere else, but it's not your own tissue. So we have a frank discussion about what's available. because not all ladies or gentlemen, if they wanted a reconstruction, not all patients have got all reconstructive options available to them. Not all of them can have it immediate. So it becomes a very long and detailed consultation. And sometimes we need to come back again to go through it again, because different types of reconstruction have different lengths of recovery and sort of different lengths of inpatient stay, different complication profiles. So it's quite an involved discussion.
Wow. Okay. So this timing that you talk about, is it possible to just tell us a little bit about how the timing works? Because there are people out there that might be thinking maybe this is something that might be of interest to them, because I don't know how much this is, available locally here in Nigeria. Can you just run us through a bit in terms of the timing?
So if you were to have a lumpectomy and it's going to leave you with a defect in the breast that's going to be very, very noticeable, we can try and reconstruct that partial defect, okay? Now, if you're very large breasted, we can do that sometimes as part of a breast reduction type operation. So the reduction of your breast, reducing the size of your breast, is centered around removing your cancer. So that's an oncoplastic technique. We're using plastic surgery techniques to take out your cancer and then generally reduce the size of your breast around where we've taken out the cancer. So we get good margins around your cancer. And it makes your breast smaller, makes your breast sit higher. So if you're very, very big breasted, a lot of ladies that we see in Nottingham actually are quite large breasted. A lot of them have always wanted to have a breast reduction operation anyway. And so we use this as an opportunity to reduce the size of the breast, take out the cancer, and also what we call symmetrizing. So if we obviously reduce one breast but not the other, you're going to be uneven. So at the same time, we reduce the other side. Okay, so that's an oncoplastic technique, using a breast reduction type technique to take out your cancer.
Right.
So if you're not very large breasted, okay, but you've got a good roll on the side, for instance, or underneath your breast, we can take out the cancer again as a lumpectomy, and then we can use the tissue on the side or underneath the breast to fill in that hole that we've created by taking out the lumpectomy. That's called a local flap, okay? So it involves using tissue from the side with its blood supply, and we're just turning it into the defect. That's called a local flap. The scar patterns for those two operations are very different, but both of those operations can be done as a day case. So we frequently do this for ladies as a day case. They come in the morning, they have their operation, they're home by the evening. In terms of the recovery, well, it takes 2 weeks for their wounds to heal, but pretty much they're back up to doing most things within that 2 weeks. And then they go on to have, depending on what else they need, they may need chemotherapy, they may need radiotherapy. Tablet therapy is a long-term thing. So when you look at the studies, those types of operations have got very high satisfaction rates because the recovery is fairly quick from them. They tend to only need one operation, as long as you get good, clear margins around the cancer, and they recover very quickly. And the breasts, they look aesthetically pleasing. So, obviously a reduced breast is sort of perter, sits higher. It also is better for radiotherapy if you've got a smaller, more compact breast, or you've had a flap, so your breast hasn't really changed all that much. It should, looking front on, it should look pretty the same as before you had your surgery. It's only when you turn to the side that you'll see a scar. So those operations have very high satisfaction along with them.
Right. Wow.
If we turn to mastectomy and reconstruction, this is a much bigger job, okay? Because obviously we've taken away all of the breast tissue and we now need to replace that. Implant-based reconstruction tends to have a quicker recovery. Again, we can sometimes do this as a day case. Tends to have a quicker recovery. It's not the same, and this is what I sort of emphasize to patients, it is not the same as having a cosmetic boob job. So it's not the same as just having your breasts enlarged.
Hello.
On top of that implant, okay? When you have a mastectomy, we've taken all. Oh, are you losing me?
Just briefly, just for a second. That's okay. Carry on.
I'll just go back. So having an implant for reconstruction is not the same as having a breast implant for just generally making your breasts bigger. Because when you make your breasts bigger, you've got breast tissue sitting on top of the implant. When you have a mastectomy, we've taken away all of the breast tissue. So you've really only got skin and maybe a thin layer of fat between the outside and the implant. So it feels very different and it looks very different. But having said that, It's a quicker operation. Again, we can sometimes do it a day case. We expect patients to be up and about very quickly from this operation, healed within a couple of weeks. The risk with implant reconstruction is obviously it is not. Can you hear me? It keeps breathing.
You just went off again for a second. Yeah. Right. Carry on. Oh, okay. So it looks like we're having some, technical issue here. Maybe it's the network. So
yeah,
it's all right. You're back now. Oh,
I'm here, but I think you keep. Can you hear me now?
Yeah.
Okay, great. So I was just trying to explain that implants are a foreign body. It keeps going.
Yeah. For some reason where we keep losing every few seconds, but let's we just carry on. So so the implant. Oh dear. Okay. So
is that better?
Right. That's better again.
It looks a bit more stable now.
Yeah.
So I was just explaining that implants are a foreign body, that they're not from your body. So your body sees it as something foreign and puts a wall around it. That's called a capsule. And with time, that capsule can become tight and it can contract and it can change the shape and the feel of the breast. You can get this whether you have it for reconstruction after cancer, or if you have it because you just want your breast getting bigger. So all women that have implants for whatever indication, whatever reason, will develop with time. That's called capsular contracture. And then you may well need another operation. So as I explained to patients, implant-based reconstruction is it's easier at the beginning. There's quicker recovery from those operations, but you may need operations in the future moving forward related to the fact that you have an implant.
Okay. Wow. So the network is not very stable. It keeps going in and out. So we have, with us, Dr. Georgette Oni, who is from the Breast Institute in Nottingham, and we've been discussing on, breast cancer and the role of oncoplastic surgery. We've had a lot of information. Oh yeah, I think you're back now.
Yes.
So, yeah, that's okay. Let's carry on. Yeah. Oh, okay. There seems to be. I don't know whether it's from my side or from your end. I don't know. It seems stable here.
Do you think it's me? Well, I can just try and link it to my phone, see if that would be better. Let's try that.
Okay. Just
give me a second.
All right. Yeah. So this is the challenge, or one of the challenges that we'll face when we go in the cloud. We're doing everything in the cloud these days, and so many people will be engaged that way as well. Okay. Yeah.
Is it working all right?
Yeah, it's working okay.
It seems to be thinking about it.
All right.
It just
connected. Yeah. Okay, so viewers, sorry, we're just trying to sort out some technical challenges that we have here, trying to make sure that we have a stable internet, both ends. You back now? Yeah, it's still glitching. Right.
It seems it's thinking about.
Yeah. Right. Okay, so we've been talking about breast cancer, obviously talking about the the role of oncoplastic surgery in management of breast cancer. We just have a few, it's just some technical challenges in terms of the network, I think, quite unstable at the moment. So are you back now? Okay, so still trying. Are you back?
Yeah, it just keeps coming and going. So for some reason it's not connecting to my phone either, which is not very good.
Okay.
It seems to be sort of behaving now.
Yeah, we'll crack on and then okay. So sorry about this. Yes.
Yeah.
Okay.
Hello. We can.
Yeah, it glitches every now and then, so it comes in and out. It's flipping in and out.
Okay, let me try that.
Yeah, I think we just carry on, and then in between we just recap again or something.
Hello.
Yeah, I can hear you. Are you there? Oh, okay.
So I can.
Hello.
I can hear you now, but I can't see you. So I'm hoping that's gonna.
Can you see me now? Okay. So it's the bandwidth from your end is a bit low now. So that's why. Can you see me? Hello? All right. So, hello? Okay, so seems that we're just waiting for, can you hear me now?
I can hear you, yeah.
Can you see me as well?
No, it's frozen.
Oh, is it frozen?
Okay, that's better. You're sort of back.
Okay, brilliant. I think it's the bandwidth. The bandwidth is a little bit low, so that's why it's okay. We have this every now and then. Okay, we can fire on. Hopefully we're back.
Okay, I'll just backtrack a little bit. So we were talking about mastectomy and reconstruction from mastectomy, and I was saying that there's broadly speaking two ways to do it. One is using implants, and one is using your own tissue. And the implant surgery tends to be oh dear.
It's all right.
Quick. So implant surgery tends to be quicker recovery, but that you will have a series of operations in the future related to the fact that you have an implant as your reconstruction.
Okay. Yeah. And off. Wow. Okay. Wow. All right. You back?
Yeah. Can you hear me?
Yeah, I can hear you. I can hear you.
Yeah. So I just wonder if we should. Can you still hear me? Can you see me?
Yeah, I can hear you and I can see you. It just freezes. It freezes sometimes and come back again.
Yeah.
Or could it be the positioning there?
Well, I don't think so. So that seems to be a bit better. Yeah.
Yeah. Still.
Yeah. So if we talk about using your own tissue for reconstruction, this is quite major surgery. It's called microvascular surgery.
Okay, so why? Yeah, we have some challenges with that one. It's not the internet is not very stable for some reason. I think it's saying
yeah, it says your connection is unstable.
Yes.
It was working very well. I don't understand what's changed. I'm not.
Yeah. What happens is sometimes when the bandwidth is low, it looks for another band, so it becomes unstable. It keeps going in and out, and that's when we have the the frozen bits. So hopefully it will find, if it gets one that is stable, then we can continue. It has to do with the bandwidth. Okay, it seems to be back, but how long that will be for, I'm not sure. You can carry on then. Just carry on from where you stop, and then we'll see how much we can. We're rounding up anyway very soon.
Yeah.
Okay.
I think it's so. Right, if we talk about using your own tissue, okay, we have to detach it from one area of the body and move it up to reconstruct the breast. That's called microvascular reconstruction. We also actually, though, can use the big muscle in the back. That's called the latissimus dorsi. So that's the one that you train with. That's your lat. So it's the one you use for like rock climbing, tennis, swimming. It's the big muscle in the back. Historically, that one has been used as well for reconstruction. The benefit of using that muscle in the back is that you can move it with its blood supply, and you don't need to do microsurgery for that. So, for instance, if you don't have a microsurgery set up in your unit, that's one way to reconstruct the breast.
Right. Okay.
The operation that I'm most passionate about is using the tissue from the tummy to reconstruct your breast. That's called a diep.
Okay, you're back. All right.
To get patients out quicker now with that. So we're trying to aim for a 3-day stay with that operation. It's a bit like having a cosmetic tummy tuck, but not really, I say, because the way that we site the scar is related to blood supply. So the scar that you have with this operation does not always sit as low as it would if you had a cosmetic tummy tuck. But if you've got a good roll in your tummy below the belly button, then that is something that we can use to reconstruct the breast. But it does involve a lot of investment at the beginning in terms of recovery time. It can take up to 3 months to recover from this operation. We sometimes have to take part of the 6-pack muscle, that's called, so the rectus muscle. We sometimes have to take part of that muscle as part of the reconstruction. And it's long surgery. So, you know, on average, we can do it in about 4 to 6 hours if we're just reconstructing one side. If we're reconstructing both sides, it can take up to 8 to 10 hours to do. So it's long surgery, it's a longer recovery. However, once you have that initial flurry of operations, that's you set for life. So that reconstruction does not need anything further moving forward. And it's going to grow and shrink with you. So if you get bigger, it's going to get bigger with you. If you get smaller, it's going to get smaller with you. Because it is your own tissue, it's going to behave like your own tissue. It's just been relocated to another part of your body. So we can use the tummy, we can use the legs, we can use the bottom. We've even started using the sort of the love handles to be able to reconstruct breasts. So there's lots of parts of the body that we can use, but it does mean having a scar somewhere else other than the breast.
Right. Wow. That's quite technical and then quite, you know, yeah, well done. So now, if we, okay, you there? I think you've gone frozen. Okay, so thank you. Now, I talked about the multidisciplinary, you know, team. I want us to actually discuss this because I feel it'll be very important. What's the multidisciplinary team? Who are the people involved in multidisciplinary team, especially when it comes to breast cancer management? If we don't have one and we want to put one together, how do you suggest we can do one? You know, locally. I know that you come to Nigeria, and I'm looking forward to the next time you'll be around and I'll be here, that we can be in Nigeria together. There's a lot that I really want to do. We want to learn from you, and then even to also, you know, have challenging experience. So tell us, what the multidisciplinary team, how does it work? How do you think, see it working in this?
The multidisciplinary team is essentially all the
okay, right, you're back.
So it's all the people that are going to be involved in the care of that patient. Okay. On imaging, So it's going to be radiologists who tell us about the cancer on imaging, pathologists, which are going to tell us about the features of the cancer when they look at them and look at it under the microscope, surgeons who are going to be involved in, you know, coordinating the care and oncology, oncology, who are going to be involved in things like radiotherapy, chemotherapy. You need administrators because somebody has got to coordinate what the outcomes of these meetings are and how that's disseminated to people.
Okay, so we're just waiting. Yeah, carry on. I think you're back now. Oh, no. So we're talking about multidisciplinary team in the care of breast cancer. Okay, carry on, Dr. Oni, Mr. Oni.
Yeah, I was just saying that the multidisciplinary team basically is involved with everybody that's going to be part of that care pathway. So radiologists who tell us about what the cancer looks like on the imaging, pathologists who tell us what it looks like under a microscope, the surgeons who are going to be involved in removing that cancer, oncology who are going to be involved in chemotherapies, radiotherapies.
Sure. Okay.
You know, nurses are going to be.
Yeah.
So I was saying, yeah, administrators who are going to be able to, who are the ones that are going to like coordinate that information, disseminate that information. So the multidisciplinary team is really revolutionized the way in which we treat cancer patients, because we put them in the middle and then everybody that's involved in their care around the outside, putting in, saying, you know, what's necessarily from their perspective, and then how we're going to put that all together as the treatment package.
Okay, brilliant. So I think it's something that I'm quite interested in seeing how we can, you know, coordinate such a team, especially around breast cancer management, for some of the work that I do here in Nigeria. And I'll definitely be speaking to you more about this. So now, what are your final, you know, suggestion, advice, you know, to Nigerians, basically, especially with your experience of how we work here in the country?
I mean, I think I always go breast awareness. So examine your breasts, know what's normal for you. That's number one.
Yeah, you're back, I think. Oh no. Right. The network is really bad, but we'll make the best use of all, you know, what we can get from it. Okay. Yeah.
Yeah, I was going to say, number one, examine yourself, know your breasts, know what's normal for you. Number two, present early. If you feel something.
Okay. Right, you're back. Okay, we can hear you. I think we can hear you again now.
We're back. So number one, examine yourself, know your breasts, critical. Number two, if you feel something, present early, seek medical advice. Number three, if there's a screening program that's being offered, engage with that if you're of screening age. Number four, if you engage with the medical. If you're coming to surgery and you can, I would seek the advice of a breast surgeon and a plastic surgeon, so that if you are. Did you catch that? So yeah, so if you've got a
it's really bad network. Wow.
Hello.
Yeah. Hello. Yeah.
Oh dear. I was saying that if you are going to have surgery and you are worried.
Okay.
If you,
yeah, if you're gonna have a surgery, yeah. Yeah.
hello?
Yeah, you're back again, but it keeps freezing.
Unstable, yeah.
It's a very bad network, actually. Okay,
Yeah.
so if you have a surgery,
I would say if you can get the advice of a plastic surgeon as well as a breast surgeon before you have any surgery, then that is a better plan. So if you, like.
Okay. Hello, yeah, you're back again, I think. No, all right. Okay, so viewers,
Hello?
yeah, carry on now, I think. So that will do the final one. Yeah,
Yeah,
you're
I
back.
think, so yeah, I was going to say if you can get the opinion of a breast and plastic surgeon before you have any surgery, that's always beneficial, particularly if you're going to need a mastectomy and you want reconstruction. And if your care can be managed in a multidisciplinary team setting, that is going to be the best way, because that means that all the players understand what's happening in your management plan. And so they're all in sync with each other and things are not being missed. So that gives you the most comprehensive management plan if everybody involved in that management plan knows what the other is doing. So be self-aware, so examine your breasts, know any differences. Sorry, my last plea, while you've got a bit of connection, is get involved in any research studies as well, if you can. So that's the only way we get represented, is if we're in them. So get involved in research. If a research program is discussed with you, seriously consider being part of that.
Really?
And you can ask as well. So as a patient, you can say, are there any research studies going on that I can be part of? Because I think it's really important that my information forms part of treatment for other patients moving forward.
Thank you so much, Ms. Oni. We're sorry, viewers, for...
I know, so sorry.
No, for the unstable, network. This happens sometimes. I think some days are better than the other with the network. That's the disadvantage of the virtual, things like this. But at least I think we've been able to grab quite a lot of information there, quite a lot of important things, which will feed what we do next.
I'm happy to come back. I'm happy to come back and do like a Q&A or something, because I know that some of it was missed in translation. So I'm happy to come back if there's lots of questions and we can go through some of those questions.
Okay, that's great. So if you have any questions, there are areas that you wanted us to touch on and we've not touched on today, please just leave your message below in the comment section. We'll pick them and then we will arrange, if it's necessary, to bring Miss Oni back so that we can even discuss further. And any question whatsoever, just leave behind. And then don't forget, if you need any help, you can also download AreaDoc, which is our mobile health platform. You will catch up with some of our doctors. They can chat with you. You can call them. It's free, and we can signpost you in the right place, a place that might be relevant. Thank you so much for joining us today, Dr. Oni. Miss Oni. I really, really appreciate your time. I know how busy you guys are, and for me to twist your arm, pull you, and drag you into this,
always a pleasure.
I really thank you so much. So I really look forward to working with you, even with the project that we're doing here. Hopefully, coronavirus will give us the opportunity to move on with our lives, as it has come to stay and live with us. So thank you so much. For our Muslim, viewers, we say Baraka de Salah, and happy new month to everyone as well. And thank you. So I look forward to meeting you again next week for another exciting topic. Thank you. Now, offline.